Hi, welcome to our next session. We will have basically rapid fire talks from MD Anderson. Our first speaker will be Dr. Woodman from MD Anderson.
Can you all hear me? Can you all hear me? I'm unmuted, and so I'm going to share my screen. I'm just having a little trouble sharing the screen. Hold on one second. Okay, I think I'm there. Can you see the screen?
Hey, we could.
Angela, I'm having trouble getting my. I'll do it through the app.
Okay. Well, we could see your screen a bit ago. You were fine to get started.
Oh, okay. Did I miss it? Okay. How's this?
It's perfect.
Okay.
Yes.
Very good. Well, I will
get started.
Make up for that minute or so here. Well, anyway, thank you very much for inviting me to speak. The title of my talk is Integration and Analysis of Disparate and Multidimensional Data from Heme Malignancy Patients in the COVID-19 Era. So just to orient those folks who may not be as familiar with cancers, we categorize cancers as non-heme versus heme. So I will be focusing on heme malignancies. These are ones that originate from cells in the bone marrow. They can be either malignant or benign, and we will be focusing on those that are malignant, where the cells uncontrollably divide, invade other tissues. And these can be both what we call liquid or solid. Liquid meaning that they are in the bone marrow as isolated cells or in the bloodstream, or as solid tumors forming a mass. And lymphoma would be an example of that versus leukemia. And so these are all cancers that are coming from normal cells, of course, of the hematopoietic pathways. And so as you can see here, we have the lymphoid, what we call the lymphoid branch, the myeloid branch, and the downstream normal cells. And when these cells at different stages become cancerous, then we call them heme malignancies. And there are a huge number of heme malignancies. You may be familiar with some of their names just in general as leukemia or lymphoma, but you can see there's many different subtypes and many different, and this is both because of the cell of origin and also because of genetic aberrations that occur that further categorize these heme malignancies. So the focus in this COVID case, and this is part of the D3CODE project that was described earlier, was that these patients actually are quite vulnerable patients among cancer patients. And I'll tell you why that is in a moment. But with the focus on leukemia, and I have to point out Dr. Thompson, lymphoma, Dr. Manasanch, myeloma, Dr. Flowers, and plasma cell dyscrasias, these all being types of heme malignancies. It's really a huge effort across multiple departments to make this, this project happen. And so the critical question that they were wanting to ask, and the D3CODE protocol was well equipped to help them answer, was can we learn more about our patients who are quite vulnerable to COVID through the protocol and data aggregation, integration, and analysis. And in addition, can we have tools that allow us to better retrieve data from patients in the community setting where they are exceptionally vulnerable, and that we would not want to lose connection with them. And so I just want to point out that, so the tools that we've built in order to do this allow us to, first of all, get daily updates on who has been tested. That's here on the left. And then we come up with who is a cancer patient, because it's, believe it or not, at MD Anderson, just having a medical record number doesn't mean that you're necessarily a cancer patient. We do screening and all kinds of other medical cancer-related things. And we pull from multiple databases across the institution, and using natural language processing and other different databases to come up with a key concept of who is a cancer patient. So daily feeds of who's been tested, what the test results are for SARS-CoV-2, and are they a cancer patient? So this is a first filtering step that we do. And of course, we pull back with false positives and false negative quality controls. Through this process, we've already identified that the heme malignancy patients are quite a bit more vulnerable and have worse inpatient clinical outcomes, both needing higher degrees of ventilation and, unfortunately, death compared to the solid tumor cohorts. And so the focus I want to put on today is one of the specific therapies that we give in the heme malignancies called CAR T-cell therapy. And I'm going to jump ahead so that I can just explain what it is. So we extract T cells from patients. We then engineer those T cells to have receptors that recognize specific features on cancer cells. And then we expand those now engineered T cells. During that same process, in parallel, the patient is getting what's called lymphodepletion, meaning that we're essentially giving them chemotherapy to rid them of the bad cancer cells or T cells that they have.
And I'm going to have to give you maybe 30, 45 more seconds.
Okay, great. Okay. And then we've infused that back into the patient. And so this process is a very long process that is very complex and requires a lot of, I can cut to the chase by just going down to here. So in order to follow these patients in the outpatient setting, we have a Zoe patient reporting outcomes app that patients can load on their phone. So this allows us to have daily answering of questions from the patients. We also have what's called CAR Talks, which is an algorithm that we run in the hospital while they're getting the therapy. So we have that data coming in. And then we also, in addition to that, have all of the D3CODE derived data from the medical record, et cetera. And then all of the data that has been derived from the department itself. And the bottom line is that we integrate both the outpatient data, the inpatient toxicity data, the D3CODE or COVID-related data, and then the data that the department itself is interested to focus on. We perform transformations across that data to integrate it, and then we can pull it into an analytical engine and do multiple different analytical analyses, including machine learning, as well as more standard statistical analyses, in the real attempt at the end of the day to identify the features that can predict an adverse effect and benefit from the CAR T therapy. And so this is essentially the big picture of what we're doing with the heme malignancies at MD Anderson in the COVID-19 era. And with that, I'll just say thank you.
Thank you, Dr. Woodman. We are moving on to our next speaker, Dr. Rojas Hernandez.
Okay, can you hear me well? Angela, can you hear me well?
Yes, we can hear you great. Go ahead and get started. Thanks.
Okay, thank you. Thank you, everyone, and good morning. I really appreciate the invitation to this conference and the opportunity in the next 5 minutes to share the experience that we've had from the benign hematology section in regards to using the D3CODE platform that Dr. Futural described in the previous section of this conference. So I'm going to talk about the features of coagulopathy in the cancer patients that we've had who suffered SARS-CoV-2 with the COVID-19 syndrome. Just to educate everyone in the audience in regards to the topic of my interest, thrombotic complications, which is blood clotting, were earlier described in the pandemic to occur in around a third of the patients that had severe disease for COVID-19. And initial observations also pointed out that elevated biomarkers, such as the D-dimer and the prothrombin time, were associated with decreased survival of these patients. In this cartoon, I try to show the complex dynamics of the immune system, the clotting system, in the presence of inflammation or in the presence of an infection, such as the viral pneumonia syndrome that we're seeing with this pandemic. And the attempt to study this initially incorporated the use of already established tools that are used in hematology to measure biomarkers of the coagulation system and try to predict which patients were going to develop clotting disorders or clotting complications during the active infection. So through the collaborators in the D3CODE team that are listed in this slide, I received support to study the questions that I was interested on, which was to characterize the features of the coagulation disorders and blood clotting disorders that our patients at MD Anderson suffered during the COVID-19 pandemic, and also to estimate how those features are impacting the survival and care outcomes of these patients during their hospitalization for the pneumonia related to the virus. So we started by analyzing the patients that prospectively and consecutively enter in the hospital for management of the COVID-19 syndrome. And we use these tools that I described before, called DIC score, to try to stratify the patients in 4 categories and correlate if the patients were suffering clotting or hematologic complications related to it. And as you can see very briefly, the higher the score, the higher the chance these patients were suffering thrombosis. And this was also related with mortality. So how to characterize and how to understand this better and take it to the next level besides identifying a subgroup of patients that are doing worse. So this is just to give you an example of an individual patient and how complex are all of these data, different biomarkers measured at the same time over a period of time, and the dynamic changes that those and each one of those biomarkers can have. So through the D3CODE, we created a platform that would gather data from the hospital and these biomarkers, would calculate or separate which patients were having the features of these clotting disorders, separated between the patients who had the infection and our patients that were hospitalized during the same period of time but didn't have the infection, and try to create that control matching to try to clear and clean for variables of confusion that could impact the analysis of the biomarkers that we were interested in. And we started finding that certain biomarkers of inflammation, such as the ferritin, the D-dimer, and also the platelet counts, were significantly different between the cancer patients with COVID and our control group of cancer patients without it, and also that there were remarkable differences between the patients that had worse outcomes in regards to having a clotting event, having a need for critical care, or unfortunately having also demise.
Let
And
me give you maybe just 20 more seconds to kind of summarize.
yes, and finally, the same type of outcomes and observations in regards to the clotting biomarkers. So my final remarks would finish with the D3CODE platform at MD Anderson has allowed us to study dynamic and longitudinal complex biomarkers in order to understand the significance of coagulopathy and inflammation in COVID patients. Also, the process of selection of match control individuals seems to be easy and versatile, and the correlation of biomarkers and hard clinical outcomes such as death and intensive care is possible and readily available through this platform. So with that said, I want to thank you all for the opportunity.
Thank you so much for speaking. Our next speaker will be Dr. Palaskas.
Hello, everyone. My name is Nicolas. I am one of the cardiologists at MD Anderson, and you may be wondering, why are we concerned about cardiovascular disease in patients with cancer? Well, cancer and cardiovascular disease are the two most common killers in the United States and in most first world countries. And so now when you have patients that also have COVID-19, you have this triple whammy of events where they have cardiovascular disease, they have cancer, and they have COVID-19. So we want to see how much worse are these patients doing when they get COVID-19, because there's been literature in cancer patients and in cardiovascular patients, but not combined, showing that they do worse when they have COVID-19. So I'm going to present to you some data, really just very minor, touching on one of our aims with our research project. And there's three facets to it. One is looking at patients with cancer and those with cardiovascular disease versus those without, and did they have worse outcomes? And then two, we actually have a multi-center registry. So we're comparing cancer patients to those without cancer. And we're looking at their cardiovascular outcomes. And so we have centers from around the nation, including New York, Michigan, and California, and including local centers with non-cancer patients that we're comparing to. But I'll tell you, the D3CODE project, which has been really beneficial for us, is we're able to aggregate this data so quickly compared to the other centers that have to do manual collection. So our data collection has been much more rapid with the data science experts that have helped us with this. These are just some of our collaborators from around the nation. I'll skip through this. And so touching on that first point of aim one, one of the things that we had to do with the data science is group the cardiovascular comorbidities. In our medical record system, there are over 10 to 15 different codes for what constitutes hypertension. So we had to group those together. For coronary artery disease, which is the middle one here, we have 30 plus codes for people who have coronary artery disease. So we had to group all these together and able to look at them appropriately. And as you can see in this table, having cardiovascular comorbidities, hypertension, hyperlipidemia, diabetes, coronary artery disease, history of stroke, TIA or CVA is stroke, cardiomyopathy, AFib, all have significant p-values for the patient being more likely to be admitted. And then if you look at admission to the hospital, again, you see the same trend for these patients needing ICU care or ventilator care. I'm not showing you that data here because of the time brevity, but showing that those with cardiovascular comorbidities have worse outcomes than those without. And then we look at a value called troponin T. So this is a marker of acute myocardial injury. Not exactly a heart attack, but you can think of it along the same lines. And so we're able to quickly aggregate all these troponin values for patients because of our collaboration with the D3CODE project. And we can look at patients before they develop COVID, on the second they hit the door with admission with COVID, what their max troponin levels are, and then long-term follow-up. We have no idea what the complication rates are in long-term follow-up. And if you get more granular, we get some more hypothesis-driven questions of looking at changes in acute myocardial injury or troponin values based on the comorbidity. Now, as you would expect, those with cardiovascular comorbidities have higher troponin levels or higher acute myocardial injury. However, you see that not having some diseases, you get higher peaks than having the disease. Now, this has driven our hypothesis to say, why is this? Are there some of the medications that these patients with diseases, are they protective of injury that you get with COVID, such as cholesterol medications like statins, things like that? And so that's what we're driving our testing forward with. And as you heard in the last talk,
I can give you about 30 more seconds to kind of finish up. Thanks.
Perfect. So in terms of last talk in thrombi, we have here looking at anticoagulants that patients are on, or different antihypertensives they're on. And the last thing I'll touch on is that we're looking at EKG data. Some of the therapies for COVID-19 can cause EKG abnormalities, including prolongation of this QT interval, which can cause very dangerous and fatal arrhythmias. And you look at above 500, puts you at a significant risk for this. And so we're evaluating these patients to see what caused this, and was it the therapy they received for COVID? And with that, I'll conclude. So thank you so much for your time and invitation to speak here.
Hi, thank you so much for doing that. Our next speaker will be Dr. Kothari.
Thank you so much for the opportunity to speak this morning. So I'm one of the surgical fellows at MD Anderson, and the talk that I want to kind of go through, it does two things. One, it's just a summary of kind of where we have been, and then the second part of it will be kind of where we're going from here. So what became particularly interested early on in the pandemic was the impact of COVID-19 on patients that needed surgery. And this was based on data early on where up to 1 in 4 patients that either had COVID or developed it in the postoperative period actually died after surgery. And much of this was attributed to a postoperative pulmonary complication. You know, for many surgeons, there's the option of just deferring surgery. But for patients with cancer diagnoses, there's a limitation to how long we can do that safely. And so while we've defined some of those postponement periods, most kind of extend from about 6 to 10 weeks after surgery. And obviously that's too long to wait, especially as the pandemic continues. And so here at Anderson, what we did is one of the solutions was just doing a very comprehensive screening and testing program for anyone who was going to be undergoing surgery. So they were screened for the symptoms, and then as long as they were asymptomatic, they would get tested, and then subsequently, as long as their test was negative, undergo surgery. And this was paired with some additional precautions like masking, patient restrictions, and then just some universal intraoperative precautions. And so, you know, initially our group set out to understand, you know, was this approach effective, and was it something that we could do kind of long term as we balanced the risks and benefits of operating during the pandemic, and then what were the COVID specific outcomes of this cohort? And so, you know, we were able to do nearly 5,000 operations using this strategy, and early in the pandemic, actually, because of kind of low local prevalence of the disease, we had no pre-op positivity, and were able to progress with operating on these individuals. And then as the pandemic progressed, and you'll see this data on the next slide, we started to have some positivity. So these are individuals who we were able to prevent and mitigate the risk of having adverse events, and then also you know, protect the staff and individuals around the operating room from developing potentially a secondary infection. And so you can see that here, once we started having some positivity, it really was associated with what the blue bars are here is the Texas positivity rate. And this was both for our preoperative testing rate as well as our preoperative positive rates as well. Importantly, after surgery, we had, up until July 24th, no postoperative COVID-19 infections, no patient-to-patient transmission, and no patient-to-staff transmission. So really supporting that this was an effective strategy, and this is data that we just published. In order to accomplish this, we had to engineer about 73 unique clinical data elements. And these are all things that went into kind of understanding surgical outcomes and really serve as a backbone for how we, at least our group overall, thinks about surgical outcomes. And so that's really been a launch point for some subsequent analyses. And so the most immediate question was, well, we have these 51 patients who were positive that we had to defer surgery. And then of course, as more and more people have COVID-19 and subsequently recover, you know, what about those individuals and the physiologic change to them that, you know, subsequently would potentially need surgery? And so we built out a framework for studying this group. So this is a secondary project using the foundational pieces from our first project that now is looking at surgical outcomes in patients who have recovered from COVID-19. And as we were doing this, because of the framework that was already in place, we found out that after July 24th, there were some patients who developed COVID-19 post-operatively. And, as you can recall, about 1 in 4 patients actually died within 30 days, at least from the early data outside of MD Anderson. And what we found was that we have a very low post-op COVID rate, less than 1%, and the mortality is about 4%. So, we're doing a little bit better. And this is the ability to show that maybe some of the cautions early on, as long as it's supported by these other safe practices, would allow us to continue doing cancer surgery in this environment. And so what the D3CODE has really demonstrated to us as surgical researchers is that during a pandemic, having real-time and flexible insight is important, being collaborative, making sure this is scalable, and then really doing something clinically applicable is important because we're able to, in real time, understand what's happening. And then moving beyond the pandemic, these same 4 principles apply because, again, this is really how we can best understand how to take care of our surgical population. And so it really sets the stage for an overall programmatic approach, which is data-driven, allowing us to marry this with some advanced analytical tools and workflow, because for the first time, we can rapidly get data that we previously weren't able to, and then really leverage the concepts of teaming, where it's this active engagement of the team to accomplish these really time-sensitive and relevant questions. So these are our collaborators. And again, I appreciate the opportunity to talk about our work. Thank you all very much.
Thank you so much for being here. I'd like to next introduce Dr. Ashley Arrow. Oh, you're muted, Ashley. You're muted.
I apologize. Can you hear me now?
Yes, I can.
And you can see my slides?
Not yet. Can you please bring those up, Freddie? Okay, try sharing screen again.
Okay. There we go.
Freddie, can you see them? Okay, perfect. You're good to go, Ashley.
Excellent. Thank you. And sorry about that. So I am a clinical neuro-oncology fellow at MD Anderson, and I am helping with a project from our department to look at neurological manifestations in patients with COVID. I will describe a little bit of the current clinical and preclinical data that led us to investigate these topics, and we'll describe a little bit of what we've accomplished so far. We know that endemic coronaviruses, which are greatly structurally related to the SARS-CoV-2 coronavirus, are neuroinvasive and invade the central nervous system, most often through the olfactory bulb. And so at the onset of the pandemic, it was a question whether or not this was going to be the case for this particular coronavirus. We have found that patients with coronavirus do present with neurological symptoms, most commonly headache and dizziness, although some other neurologic manifestations such as muscle weakness and muscle pain, as well as atypical nerve disorders, have also been described. The mechanism has been recently clarified as that neurons and glial cells in the central nervous system do express the ACE2 receptor, which is required for the virus to enter the cells and replicate. There are certain characteristics described out of both China and Italy from early on in the pandemic that patients with neurological symptoms have certain serum laboratory parameters which may signal that they are more vulnerable to developing confusion and other neurological symptoms. And these in particular included elevations in renal function and lowered white blood cells and blood clotting platelet cells. Also, some recent work has confirmed that in mouse models, this coronavirus is neuroinvasive as well. So the aims of our project are threefold. First, we seek to define the incidence and clinical phenotype of neurological complications associated with the coronavirus in cancer patients. Second, we hope to describe the clinical risk factors in these patients that may portend neurological complications. These variables include age, functional status, cancer diagnosis, time from cancer diagnosis, concomitant therapies for cancer, including immunotherapy, and whether or not patients have any underlying neurological conditions such as brain metastasis or primary brain tumors or stroke. We want to look at these neurology-specific clinical variables as there's a phenomena in neurology that's quite well known called recrudescence. And when someone has had prior neurological injury in the setting of an infection, those symptoms that were previously seen with the neurological injury that may have since become masked or less obvious can sort of reappear. And so there's kind of a wealth of clinical experience to suggest that patients with underlying neurological comorbidities are likely more vulnerable to developing neurologic symptoms. And our last aim is to identify laboratory markers, both in the blood and also in the cerebrospinal fluid that bathes the brain and the spinal cord, to identify if there's any markers that also could give us a clue as to which patients are more vulnerable. And so over in the column on the right describes some of the neurology-specific data elements that we've been looking at. A lot of our work thus far has, which we'll show in a couple slides, is focused on not only identifying patients with underlying neurological comorbidities and making sure that those cohorts are accurate, but also building up some of these variables which are very specific to neurology, including lumbar punctures, EEGs, and MRIs. So we'll discuss a little bit about that as well. I would like to, before I go further, thank the team that has been working with me and my PIs, Dr. Woodman, Dr. Maj, and Dr. Harrison, that have really been guiding me as we worked on this project. This is a representation of the data elements that we've been looking at and how we prioritize and keep track of our work. Here, I'm just showing how we build a population of interest. In this particular group, we were looking at patients who had been previously seen in the Brain and Spine Center by any of the following departments: neuro-oncology, neurosurgery, radiation oncology, or neurophysiology, as these would be patients that had underlying neurological conditions. We also are looking at specifically at patients with primary brain tumors as well, which we segregated out from this population using a number of different data sources, including natural language processing from the clinical notes, COVID test results, and also comorbidities, histories, and ICD codes from the electronic medical record. We've also been looking again at neurological symptoms. One of the larger projects that we've been working on is identifying patients with encephalopathy. This graphic from the Alzheimer's Association does represent, I think, very well the different things that can go into encephalopathy, which is synonymous with confusion or delirium. These things can be coded in the electronic medical record and described in a variety of different ways. And so we've been building up sort of what search terms are appropriate that accurately capture this diagnosis and what do not, because some of these elements in the list over here, which have the word encephalopathy, are actually other separate and unrelated conditions. And so that has been a difficult.
Doctor, I'm going to ask you to try to summarize as much as you can in the next 30 seconds. Thank you.
Sure, thank you. We're also looking at electroencephalography, which is brain waves. We've so far identified 12 patients who have had abnormal brainwave tests within 1 week of COVID diagnosis. We're currently also looking at MRI reports to see if we can use that to identify patients who have underlying brain metastases or primary brain tumors. We're also looking at cerebrospinal fluid. The way that we look up cerebrospinal fluid results in the electronic medical records system is very cumbersome. So we've been using the D3CODE project to streamline this. And just representative, we've only found a few patients so far that have had cerebrospinal fluid testing after COVID diagnosis. And thus far, we've not seen evidence of neurological manifestations, either in terms of symptoms or in the spinal fluid results. And the last thing I'll mention briefly is that there is an increased risk of acute stroke in patients with coronavirus. There's actually an increased risk of stroke in patients with flu as well, but the risk of stroke and coronavirus exceeds that. There are several underlying potential biological mechanisms. The other issue is that patients are more reluctant to present to medical attention, and due to coronavirus restrictions and PPE, we are wanting to investigate whether or not the door to needle time, or the time from when a patient presents to when they get treatment for acute stroke, is lengthened in the setting of the pandemic. And we say time is brain because several miles of brain cells die per second in an acute stroke. And so really every minute matters. So we've been looking at defining patients who receive acute stroke therapy and whether or not this time that it takes to implement therapy is now longer in the setting of the pandemic. And lastly, we've just recently published an abstract with the Society of Neuro-Oncology looking at outcomes of patients with primary brain tumors in the setting of the pandemic. We have found that some patients do have alterations in their therapy for cancer management in the setting of the pandemic, but that this so far has not borne out any worse outcomes from their cancer. And so this will be something that we also pay close attention to on longitudinal follow-up. So that concludes my presentation. Thank you so much.
Hi, I'd like to introduce our next speaker, Dr. Brock.
Today, I'd like to acknowledge the members of my lab, as well as the D3CODE team and Carol Wu and Myrna Gajoy from Diagnostic Radiology. So we know that CTs are required for many COVID positive patients to identify the extent of lung involvement. This creates the need for automatic diagnosis and outcomes prediction, as well as segmentation of ground glass and consolidation. There's also a clinical interest in enabling deformable modeling to relate longitudinal images in cases with advancing COVID-19 status. So my lab, the Morpheus lab, has a research focus on image-guided cancer therapy, including applications of biomechanical modeling and image analysis to improve planning, delivery, and assessment of focal cancer therapies. We've also been developing deep learning segmentation and outcome prediction models. And so our goal was to try to translate some of the work that we had been doing in the cancer setting to aid in the research for analyzing the COVID images. So here's a summary of the data. It's a combination of publicly available data sets as well as some cases from MD Anderson. This data curation is in progress. We've also augmented this for some of the purposes of the segmentation work to include advanced lung cancer patients because of some of the similarities that we see between these. So I'd just like to rapidly go through the three projects that we've been working on, the first being auto segmentation. So we have previously developed deep learning based methods in the GYN CT setting as well as the liver CT setting. So we applied both of these algorithms to the COVID lung cases. So the first was a two-step 3D UNet with an atlas-based initialization. This was a platform in the RayStation treatment planning system from Research Laboratories. This was trained on a mix of the COVID and the advanced stage lung cancer patients and then validated on a cohort of both. And both in the training and in the validation set, we saw a very high dissimilarity coefficient of the lung contours of 0.98. We also looked at this only on the COVID positive CT scans because this was a 2D model. It was trained on the Deep Lab V3 Plus with an exception backbone and was evaluated on 6 externally withheld data sets and had a very similar average dissimilarity coefficient. So you can see those results for the 3D and the 2D models shown here. However, the identification of the ground glass and the consolidation that's shown here in manual segmentations is a much more challenging scenario. And so this was very similar to the work that we had been doing in developing a method to detect and segment liver tumors on contrast-enhanced CT scans. So you can see the liver with the nodules here and the automatic identification. So this is a summary of the liver segmentation work that we had done where we took publicly available data sets from challenges, trained this hybrid WNet where the left side represents a pre-trained 2D dense net, which is then concatenated into a 3D dense net architecture with several layers and convolutional blocks. So you can see the excellent performance in terms of dissimilarity coefficient as well as detections. I'm not going to go into all of those details in the interest of time, but our hope is that we can take this more complex algorithm and apply it to the ground glass and the consolidation areas. So this is still in training, so I don't have any results for that yet. The next is the deformable registration. So here's an example of a case from MD Anderson that had a pre-COVID CT scan and then 2 months later presented with COVID. And so you can see the ground glass and consolidation present in the lung.
Dr. Brock, I'm sorry, you have about a minute left.
Okay. And so the idea is that if we want to longitudinally track these cases, you can see the independent vessel registration here. This is fed into a finite element analysis with a deformation vector field. This shows the results of the rigid registration, a more standard intensity-based registration, which provides a lot of distortion, and then better preservation of the texture with this and the improving accuracy. In my last 45 seconds, I'd just like to touch on the diagnosis and outcomes prediction. So this is a method that we've used in collaboration with Stephen Lai from Head and Neck Surgery to develop an AI technique to predict patients that will have osteoradionecrosis. And so we fed into this algorithm lung CT scans with COVID and patients that had cancer, and they're automatically segmented contours from the previously developed algorithm, and with the intent to also in the future include clinical data. And so the preliminary results of this shows that we have over 90% accuracy in predicting between COVID-19 or cancer. So in summary, the goal of this work has really been to translate some of the work that we've done in the image-guided cancer therapy setting into the COVID setting. So we translated some of our deep learning methods to segment the lungs and are working on ground glass and consolidation. We're applying our biomechanical model registration to enable longitudinal evaluation of the changes in lung involvement, as well as investigating AI-based classifications and outcome prediction. So this is definitely a work in progress as we continue to curate the data, and it's absolutely a team effort. Again, acknowledging the members of my lab, the diagnostic radiologist, and the D3CODE team. Thank you.
Thank you so much. I'd like to next introduce Dr. Wu to present on his work.
Thank you for the invitation to present my project entitled Habitat Imaging for COVID-19, Discover Clinical Relevant and Actionable Imaging Biomarker. At MD Anderson, I'm building a new lab, a data science lab that focuses on developing machine learning approaches to extract meaningful features from both radiographic and histopathological data and use them to inform the cancer patient's treatment. And more importantly, we want to correlate and combine this multi-scale information together to better inform the cancer patient's treatment. These slides introduce the concept of habitat imaging derived in cancer field. As we all know, cancer contains many regional distinct subclones. So we propose a habitat imaging aims to capture this intratumor spatial heterogeneity from these imaging scans. This slide shows the computational approach we proposed to fully automatically divide the tumor into these habitat regions based on two-step unsupervised clustering. First, at the individual patient level, the tumor is over-segmented into a large number of superpixels. Then at population level, we run this clustering again to identify the optimal number of these habitat regions existing with this population, and then consistently partition this whole tumor into this newly identified habitat. And this habitat map summarized how this spatial heterogeneity reflects. We apply this approach to study the locally advanced breast cancer and show its value in predicting the breast cancer recurrence after neoadjuvant chemotherapy. And lately, we used this algorithm to also study head and neck cancer and found that the longitudinal change of these habitat phenotypes can predict the recurrence after concurrent chemoradiation. Supported by MD Anderson lung cancer moonshot, we are using this idea to also predict the response to immunotherapy-treated lung cancer patients. And moreover, by correlating this imaging with the immunogenomic data, we are going to explore the lung tumor microenvironment that gives rise to these habitats. Here, we are now extending the habitat imaging concept to study the lung infection patients of the COVID-19 And in this M1, we specifically hypothesize that beyond the known subregions read by the radiologist on their daily practice, such as the GGL and consolidation, the habitat imaging will allow us to identify these subtle but significant infection regions and patterns as a knowledge discovery approach. In the M2, given these identified...
I can give you about another minute.
Sure. In the M2, give the identified habitat maps, we will use the deep learning-based algorithm, such as autoencoder, to automatically extract the habitat features, and simultaneously on this latent space to cluster the patients into different imaging subtypes. And we will test the clinical outcome for these different imaging groups. And moreover, we will pair these COVID-19 patients with a group of pneumonitis induced from the immunotherapy-treated melanoma patients. This will allow us to study the specific habitat patterns that are associated with just the COVID-19 patients. In this M3, more interestingly, based on the collected peripheral immune profiles, we will start to explore the underlying immunogenomic correlates for the habitat imaging phenotypes with the radiogenomic analysis. With this, we can build the imaging models as a virtual biopsy to monitor how the immune microenvironment changes during the treatment. And this will provide physicians with these urgently needed biomarkers to better manage the COVID-19 patients.
Dr. Wu, I'll have to cut you off here. Okay, great. Thank you.
Yeah.
Thank you so much for speaking. We'd like to get to our last speaker, Dr. Soisel. Thank you for being here. By the way, you're muted.
Yes, I'm trying to unmute myself. Thank you for having me. My name is Ergin Soysal. I work in MD Anderson Cancer Center AI Department NLP group. Title for my talk is to extraction of robust insights from the evolving literature in response to COVID-19 pandemics. I will try to summarize our attempts of work to extract some insights from the most current COVID-19 literature to provide some leads or directions to our COVID-19 related research as a part of D3CODE initiative in MD Anderson Cancer Center. We attempted to collect some conceptual associations with certain use cases, with certain factors, or for certain concepts of interest to collect some research directions and data to help researchers to make their decisions on their research directions. Considering that a rapidly evolving body of knowledge based on the different centers on COVID-19 research, it is crucial to collect some up-to-date information from local experiences all over the world. So based on this, we this requirement in such a rapidly developing, spreading pandemics, and it is crucial to collect some data and make some decision and find the factors related to confinement and the control of disease as soon as possible. For this purpose, scholarly articles, scholarly publications are the most robust and reliable way to do this. For that purpose, as the initial use case and initial data for proof of concept, we picked a good, a well-maintained COVID-19 data set, namely CORD-19, which is maintained by Allen Institute for AI, which was maintained quite frequently by this institution. And this dataset contains all coronavirus family with focus to SARS-CoV-2 and COVID-19 in focus. So in this dataset, we focused on the 3 use cases to begin with. First of all, one of the important factors was the mortality rate of disease. What are the factors affecting the mortality rate of the disease? And the second one was the ventilator use, and the last one, the hospitalization and the patients, which was the initial concern and resource planning in the control of disease. If you give it a quick insight how the data set changed over the time is between those three different data sets, we only have 1 month or 4 weeks-ish interval. And you can see that it is doubling, more than doubling per month. So this is one of the reasons why we would like to streamline our data processing and extraction of this related and interesting concepts to plan our research direction. We use some methods from natural language processing as well as data science. Initially, we collect all the data sets and make some change analysis, because over the time these data sets are being changed, and we need to trace the change over the time. So initially, we run the MetaMap with certain semantic filters to filter out, locate some interesting clinical concepts. And next, on the COVID-19 dataset, we try to collect relevant dataset to COVID-19 related in particular, or at least the SARS-CoV-2 related publications with the clinical inference. And then next step, we extracted the actual concept of interest, such as mortality rate or hospitalization or use of ventilator. And then we collect when we locate each concept within the sentence, we gather any kind of mentions and negations and all kind of linguistic features of the sentences to further analyze this data by using some machine learning and statistical approaches. In the machine learning approaches usually focus on clustering methods of the findings from
Sorry, we have to end this session. I can give you maybe 15 seconds to just kind of summarize.
Okay. Okay, then I'm just directly jumping to summary after I completed this slide. Okay, so these methods were helping us to detect the actual interesting topics in the further research as the further research topic. So this is the architecture of system we've been working on. So this is a general view of how the things are collected after we located any relevant concept in the text and surrounding concepts, and how we collect the important and relevant and interesting concepts based on our data analysis. In summary, we are using COVID-19 corpus to develop using some natural language processing as well as statistical and machine learning models to develop a pipeline. And the initial use cases were mortality rate and the need for ventilation or hospitalization with COVID-19 and all related and relevant concepts that may have some impact on these important factors. And these, we assume that we believe that these novel approaches will facilitate the generation and digestion of new knowledge and information to proceed with the further research with the clinical applications. We also plan to use this pipeline in future with other corpora to use or identify some research areas in the cancer domain. Thank you.